All right, so while y'all are filling that out, I'll introduce our speaker for tonight, though she probably needs no introduction. Dr. Selena McGee is the visionary founder and owner of Bespoke Vision, a private practice that offers patients a wide range of optometric care with its dry eye center, specialty contact lens clinic, and aesthetics suite. She is a renowned national and international speaker, an adjunct assistant professor at the Northeastern State University College of Optometry. She's on the faculty at the Oklahoma Medical Research Foundation and serves as the president for the Intrepid Eye Society and the secretary of the board examiners in Oklahoma. She's a fellow of the Academy and a diplomate of the American Board of Optometry and past president of the Oklahoma Association of Optometric Physicians and past trustee on the SECO board. I don't know when you have time to sleep because she's also the co-medical editor of Modern Optometry and associate editor of Presbyopia and the Aging Eye. So she's an expert in Demodex. I love hearing all of your research updates that you've done. And my favorite part is just how you make it so clinically applicable to manage these conditions. So here are our financial disclosures, all of which have been mitigated. And we look forward to hearing from you. So thank you for joining us tonight.
Perfect. I was just looking at the poll too and like the results. So you guys are a smart group out there always. And there's lots of things we can learn tonight. So I'm excited to be here. Thank you guys for tuning in on a Monday night. And again, all financial things have been mitigated here. If you have questions, my email address is actually at the end. So I'll make sure that you guys have that. So we got the privilege of doing this focus on eyelid margin health. And you guys that know me, I've been pretty heavily focused on this probably for at least the last decade. And we have some amazing things that are starting to come to light and come to fruition for us to help us in this category. And I have a talk that is specifically optometry's next frontier, and it's ocular adnexa. And this takes a pretty deep dive into eyelid margin health because everything kind of starts there. And so there's a paradigm shift in how we assess patients and how we manage patients. And so this came together through one thing that wasn't in my bio is I currently serve as the president of Intrepid Eye Society. So myself and five more of my colleagues, my close dear friends in Intrepid, got together and talked about eyelid margin health. And so a lot of the things that you're going to see in this came about because of that publication. And it was with Jackie Garlick, Cecilia Ketting, Jacob Lang, Nate Lighthizer, and Mark Schaefer. And so as we go through this, there's things like that trickled throughout it, but there's a lot like here depth-wise, not width-wise. So this will be fun. There again is my financial disclosures. But here was the consensus paper. And what we wanted to like really think about and what I want to talk about tonight is exploring like the pathophysiology, like why should we really care and why are the eyelids so instrumental to the ocular surface health? And I'm going to hopefully be able to connect some dots for you guys and make this very like clinically relevant. And we'll talk about some specific diagnostic techniques. We'll talk more about just strategies around how do we talk to patients about critters on their eyelids and Demodex blepharitis. And then we'll talk about, okay, how do we implement new things in our clinics without wrecking clinic flow? The good news is we can do it pretty simply. And then how do we implement and change? And I like the word evolve because it's been a year since we had the first FDA approved therapeutic for Demodex blepharitis. And certainly the way I think about it and the way that I manage patients has evolved through that year. So I'll share some of those things too. And then, we're going to talk about ocular surface, but it all starts with the eyelids. And so that's where I really want to, again, spend our focus on eyelids, because once we understand the anatomy of the eyelids, the fact that it is different, it's, half a millimeter thinner than the rest of the body, it behaves differently, and it's skin. And so there's a lot of things there that we just never, at least I didn't really learn about, because it is an extension of the face, but I want to get like a little more intimate with those details. And then we're going to talk about meibomian gland dysfunction and how all of that ties together. And then I have, periorbital abnormalities. When you start talking about the orbicularis oculi and all those little crow's feet that you see in that image, that's where the blink starts. And so if we're doing things in that area to soften those wrinkles, we may have an unintended consequence down the road. And so there's a lot of things that tie all of this together. And then we can talk about treatments. But I really want to make the connection for you guys on how this all relates and what can we do for our patients today that's different than we could do yesterday, and kind of take a little glimpse into what I think the future holds for us and for our patients. So we'll talk about facial anatomy and eyelid skin and what's unique about it and how that behaves and acts. And here's how we look at patients, right? We talk to them, we get their chief complaint, we have a fun conversation and check in, and we kind of start here. And there's a lot of opportunity to look at skin and look at eyelids and see what's happening before you ever dive behind the slit lamp. And so that's learning number one, is being an astute observer of your patient during all parts of the exam, whether you're just walking down the hallway talking to them, whether you're sitting in to greet them, whether you're having a conversation as they talk. Those are all opportunities for us to be looking for how their eyelids interact with the rest of their face, how often they blink. Do I see redness? Do I see pigment? What do I see and what am I observing with this patient? And so that's learning number one, is just to approach patients in a different way and to think differently. When we look at the anatomy, remember that all of this again starts with that orbicularis oculi and that muscle, which it's a circular muscle, right, that controls eyelid closure. It's essential for blinking. It's essential for moving the tears around. But that is where the initial blink starts. And we'll get into some more details about what that means for the meibomian glands. But it all starts with that muscle. And then remember the tarsal plates. Those are the firm, like fibrous plates that give us structure to the eyelid and maintain the shape and integrity. And then you've got the levator muscle that inserts, and often that levator dehisces from where it inserts into the tarsal plate. And then you wind up with, aponeurotic ptosis. That's a very common thing that happens. And so these are all things that we can observe with our patients. And when we look at how patients use their eyelids, how they blink, how they use the muscles, what they're doing with their faces to move muscles around. Remember, the frontalis muscle is the one muscle that is an elevator, so it pulls everything up. And often if patients have droopy eyelids, then they will, use that frontalis muscle to recruit and pull up the eyelids as well. And then of course, our orbicularis oculi, our corrugators, and our procerus are all depressors. We've all had those patients with Bell's palsy. They can't have a complete blink. They have partial eyelid closure. They wind up with exposure keratopathy and a lot of dangerous things that happen with that. So we've all experienced that firsthand. What happens when that orbicularis oculi doesn't work properly? And that's a pronounced version of that. But what happens if it's just mild? What happens if you're staring at your device and you're, reading on your computer? What happens to that whole process, right? So that's what we're going to think about. And then this is where I was talking about, remember that levator muscle has that levator aponeuroses, where it turns into that tendon and it inserts into the tarsal plate. And, where that insertion happens is where the eyelid crease is. And then at the tip of that, underneath that tarsal plate, we have meibomian glands. And when the orbicularis oculi starts to squeeze and blink, we start there, and then a whole lot of things happen. And at the end of that is the meibomian glands. And we squeeze that muscle of Rylan, which I have a picture of, that lives at the orifice of that meibomian gland. That's what secretes meibum onto the front surface of the eye. But if you back up and reverse engineer that whole process, if you have an orbicularis oculi that, just for example, has been paralyzed because of neurotoxin, you're going to have a less hard blink. It's maybe not be noticeable or perceptible to like the naked eye, but the amount of blink and force that you get is going to be different. So those are things to just consider. And when we reverse engineer this, that's important. And it's important to take in what the patient's doing all day long and how they're using their vision, because that blink rate and the blink quality eventually winds up working on the meibomian glands or not working on the meibomian glands because the muscle of Ryland couldn't function and couldn't work. So I think that's, what can go wrong. And it's eyelid health and habits. And we see our patients often doing things that we wouldn't choose for them. Those can be some awkward conversations. And, we've taken a deep dive into that, through Woo U and through other courses. So I'm not going to spend a lot of time here other than to say we have to have these conversations around eyelid health and habits, because a lot of these things start here. Lids, lumps, and bumps. If we're going to talk about eyelids, we can't not talk about that. Remember that the skin around the eyelids is 0.5 millimeter thinner. It's very susceptible to skin cancer. So reminding your patients as you look at them, I'm looking for lumps and bumps. Remember that this is the most common place on the body to get skin cancer. And the patient is going to look at you and go, what? Why? And then ask them, when was the last time you put sunscreen on your lower eyelids? And they're like, never, it burns and stings. Exactly. So the only way that you protect that from the sun is by good ophthalmic sun lenses. That is a really easy conversation that gives so much value to the patient. I use that every day, all day long. It's one of my favorite things to talk about with patients, especially new patients, because they've never heard it. Blepharoptosis, we're not going to spend a ton of time on tonight. And then rosacea, right? Rosacea is a chronic inflammatory skin condition. It affects the ocular skin and creeps up into that. And we're going to talk about a lot of comorbidities here, whether it's with rosacea or just, eyelid health and habits and what can go wrong with eyelid health. I'm going to spend some time on this slide because this is where we make all of those connections and how we put all this together. And it looks really complicated, but this is one of my favorite images that came out of the TFOS-DUCE-2 report back in 2017. And I'm going to start on the outside circle and work our way in, because this really helps us understand the whole process. And when you think about the definition of dry eye disease, Don Korb said it best. It's when the ocular surface structures fail to protect itself from desiccating stress. So when the ocular surface structure fails to protect itself from desiccating stress. What the heck is desiccating stress? Well, guess what? Blepharitis right there at the top. Meibomian gland dysfunction. Any kind of new prescription medication, whether it's topical or systemic. Allergies. Putting a contact lens on the front surface. The environment that we're working in, living in, sleeping in. If they've had refractive surgery, if they've had cataract surgery, Sjogren's syndrome, other autoimmune diseases, those are all things that cause desiccating stress. Tonight, we're going to talk about blepharitis and meibomian gland dysfunction. And when you have desiccating stress and you have inflammation on the eyelids, or your meibomian glands no longer function the way that they should and produce meibum onto the front surface, what do you have? That little arrow goes straight into tear film instability. Once you have tear film instability, then you get hyperosmolarity. All that means is your tears evaporate too quickly. So they're leaving the front surface at a more rapid rate than what you can make. So it's a supply and demand issue. And when you have hyperosmolarity, it's a higher salt content, right? And we can measure that on the front surface. We can't see that at the slit lamp. We can see the after effects, which is cell damage, apoptosis of the conjunctival and corneal cells, because we see that with corneal staining and conjunctival staining. But we can't actually see hyperosmolarity, but we can measure it, right? With there's a device called a Scout Pro. That's the only way to measure it. So I use that basically as my IOP for dry eye. But once you have cell death and cell damage, now you get inflammation. And once you have inflammation, then you get cytokine release. You start to lose goblet cells, which make your mucin that everything sticks to. The lacrimal gland stops producing, and then the meibomian glands start to have these lipid changes. You have lipid changes, now you have more tear film instability. Then the flora and homeostasis starts to fall apart, and the flora changes. So now you have organisms that grow that shouldn't be there. And then you have esterase lipase release, toxins, you get more eyelid inflammation, you get more lipid changes. The actual melting point of the meibum goes up. That's why you see patients with toothpaste instead of olive oil, because literally the temperature of the meibum's melting point is different. And so that's how all of this is connected. And so if we're trying to manage dry eye disease, or we're trying to manage meibomian gland dysfunction, and if we don't manage the eyelids, we're missing a really big piece of the puzzle. And I always ask myself, when I have a patient that I'm managing and they just don't seem to be getting better the way that I think they should be, or where they are in their journey, I always pause and ask myself, okay, what did I miss? I missed something here. And a lot of times before, I was very intentional about looking at eyelids. I had missed the fact that the patient had Demodex Blepharitis. I had missed the fact that the patient had floppy eyelids. I had missed the fact that they had, these tipped forward lids that were really loose, or I missed conjunctival cheilitis. Like, there was a lot of things. So I think that's always a good question for us as clinicians, to just pause and go, this doesn't make sense. What did I miss? And think about that and kind of take a step back for a 30,000-foot view and get out of the trees. But I love this slide because it sets us up for everything else. So hopefully that explains this image and how all of this is interconnected. It's crucial to the rest of the ocular surface for patients to have eyelid margin health, and for that area of the eye and the lid to be healthy. It's a line of defense, right? The eyelashes and lids are there to protect the front surface. It keeps things off of the front surface. We are constantly bombarded by little particles and dust and debris and pathogens, things in the air, and our eyelashes and our lids are constantly at work keeping that off. And so it's just a good reminder that our eyelashes aren't there just for adornment and for people to do things aesthetically with them. They serve a purpose. And so it really makes us mindful of what we're doing with lashes. So tear distribution, remember that blink is moving those tears across the front surface in an evenly distributed kind of way. And that maintains that healthy tear. And remember, our natural tears have about 2,000 different components. So it's vital. That is the first refractive surface that light is interacting with. That is the most powerful part of the whole refractive system, is that tear film. Why do our patients come in to see us? They want to see well. They want to have clear, comfortable vision. That is our purpose, is to deliver that. And if we don't have, and we're not looking for eyelid margin health and walking patients through that and managing that, we're missing a big piece of that whole refractive system. And again, looking at preventing excessive tear evaporation, lubricating the front surface, all of those things promote that stable tear film that we need to see well consistently. So, I talked about these muscles, and I think it's just so important to really hammer home that orbicularis oculi is where the blink starts, and the muscle of Ryolan is where the meibum gets pushed onto the front surface, and those all work in conjunction together so that you get that proper tear distribution and you prevent your natural tear from evaporating. So again, those key structures, we've already kind of gone through this, but this is just another image, looking at how all this goes together. and looking at that levator where it inserts into the tarsal plate, where those meibomian glands live inside the tarsal plate. And then that little muscle of Ryelin sits at the top of that meibomian gland, and the orbicularis oculi on the other side where all of that blink starts. So remember, we've got about, 25 to 30 meibomian glands, lower lid and upper lid. Eyelashes, we have about 150 lashes on the upper lid. And then don't forget about the lacrimal puncta and like where things are draining. That can sometimes trap us if we're in thinking that the patient has epiphora because of tear film issues. It's always like a really good idea to look at that lacrimal puncta and make sure that things are flush, that we don't have epiphora because we have a drainage problem. But remember that the tear film is like a river, not a lake. It's not stagnant, and you wouldn't want it to be, right? Because you would have inflammation and you would have bacteria just sitting on that front surface. And we've seen what a stagnant pool looks like versus a river, right? And so think of this whole system. It is very much a river, and we need all of those things to work together so that it all flows the way that it should to maintain homeostasis. So again, there's our little muscle of Ryelin that pushes that meibum up and onto the front surface. And just a good like reminder for anatomy there. So functions of the eyelid margin, again, tear film stability, because it's moving everything across, protecting the front surface, keeping things off of the front surface. We blink. We've all had that patient that we're refracting and they're like, wait, just let me blink a couple of times. Okay, now it's clear, right? You're done at that point. You can diagnose that we have a problem with the tear film stability. And then overall eye comfort. I mean, how many patients are uncomfortable through the day, uncomfortable in their contact lenses? If they're asking the question, and I learned this the other day from Britt Gustafson up in Minnesota. She asked her patients, what time of day do your contact lenses dry out? And I love that question because it lets people answer in a way like, oh, maybe a lot of other people's contacts dry out. Maybe it's that this, it makes it okay for them to be truthful in that moment and not answer, how are your contact lenses doing? Oh, they're fine, right? That doesn't give you any information or any runway to manage or change expectations. And so I love that question that I learned from her. So factors contributing again to eyelid margin health, that tear film quality is contingent on the lipid layer, and that's coming from the lids, right? And then that's protecting the aqueous layer that has all the good things in it. And then of course the mucin layer where the goblet cells live and the glue that everything sticks to. So all of these things go hand in hand. And I don't want to spend a ton of time here, but we do need to talk about this because certainly factors contributing to eyelid margin health are cosmetic toxins. And it's makeup, it's mascara, it's eyeliner, it's eyeshadow, it's removing eye makeup and makeup. It's the products that people utilize. And then it's lash products like extensions, like tint and lifts. All of those things will play a role. And then of course, looking at ingredients, do they contain formaldehyde emitting donors, parabens, fragrances? Do they have prostaglandin analogs in them, synthetic, that don't have to be reported to the FDA? Those will all contribute to eyelid margin health because they're going to harm and cause us to lose homeostasis. And we're going to wind up with issues down the road. And again, it's one of those questions like, okay, I missed something. Let's talk about what you're using on your eyelids. Let's talk about how you're taking it off. Those are great questions. If you see somebody with long lashes, ask the question, are those natural? Or are you putting something on them to make them look like that? Those are all ways that you can incorporate that into your normal just clinic flow and how you have conversations and, walking through with the patient behind the slit lamp. You guys know me, I like to talk, right? And I ask a lot of good questions, but when we go through an exam, I'm talking the whole time to the patient. There's never a moment of silence. Silence for patients feels like you're looking at something bad. And the things that go through a patient's mind of, gosh, the doctor's really quiet. What are they doing? What's happening? Is something wrong? Like, I just found early in my career that it caused a lot of unnecessary anxiety on behalf of the patient. And I want my patients to have the best experience possible. That's why I named my practice Bespoke Vision. It's about the experience. And I never want them to, feel like any kind of anxiety because of something that I'm doing. So I use that opportunity when I'm examining the patient to tell them exactly what I'm doing and why. And it starts with the eyelids, and it starts with, the question of having the patient look down. We'll get to that. Having that sunscreen discussion, looking at skin. Have you noticed that, does your skin like stay red? Does it seem like it gets worse when you have alcohol, or when you are outside? Do you wear sunscreen? Like, those are all things that you can like tuck into as you're talking to the patient and examining the patient. So you're not taking up an extra time because you're doing it as you're looking at the patient. So, diet plays a big role, factors contributing. So none of us probably have the ideal diet. It could always be better. I know mine certainly can be, as I wolf down, food between my 7:10 tech check and hopping on with you guys at 7:25. So, a balanced diet in essential fatty acids, omega-3s, are highly influential to the meibomian gland function and tear film stability. And, having the right cofactors to make sure the patient absorbs what you're giving them. Having a well-balanced diet, antioxidants like ACE, zinc, we all know those things help the inside of the eye, but they also help ocular surface as well. So it's a good idea to just have patients understand what good visual hygiene looks like. So maybe this is something that you tuck into. You want to have your best vision for life. Here's some things to consider in your diet. Here's some things to consider when we're, thinking about how we move throughout our day. When we're looking at blinks, and this is one of my patients that we're just looking at how she blinks. Do they have complete blinks? And do they blink regularly? Are they partial blinks? What does that look like? And we're looking at interferometry there on her. You can see that little kind of like triangle at the bottom with like the kind of oily part of her lipid layer. So we all know that that blink decreases with screen time, and the type of blink also goes down. And we've already discussed pretty heavily how all that ties in together. So let's talk about disorders. And I'm just going to jump in the chat real quick because that's a good like kind of breaking point. And I want to make sure that I haven't missed anything from questions. Hi from Alabama. Hello. Okay, good. So we are caught up there. All right, so common eyelid margin disorders. And when we think about blepharitis, this is where things can really go awry, right? This is a common inflammatory condition that affects the eyelid margins. And it makes an impact on ocular surface health. And we just went through a whole bunch of steps to understand why. So let's talk about the different types of blepharitis, because there are different types. We have anterior blepharitis, which often affects the base of the eyelashes. It can be bacteria that's causing the blepharitis. It can be Demodex blepharitis. We can have seborrheic dermatitis blepharitis. Those are all different causes that will cause problems. And then we can have posterior blepharitis. So that's when we're thinking about the meibomian glands, how they function. Are they dysfunctioning? And how are they contributing to the tear film composition and makeup of the tear film stability? So all things good. And all right, so let's talk about kind of each one of those. One of the most common things that we're going to see, and I see younger and younger and younger patients with this, is meibomian gland dysfunction. It's a common condition, right? Honestly, we need to be talking about this to every patient, because over time, what happens is we have these lovely glands like you see up in that middle picture, and then we wind up with these little nubs and stubs at the end of the day because they start to get very unhealthy, they become blocked, and we start to lose glands, and we don't remake these, right? And chronic inflammation leads to this. And then we wind up with tear film instability. And it really is very difficult to manage ocular surface when you have no meibomian glands left functioning. So it is very common. It happens, for a lot of people, most people in their early 20s. But I've got some 12, 13, 14-year-olds that have already lost half of their meibomian glands. And I think that it's probably related to digital device use. I think diet is a big role. I think both of those things are, causing major problems. And we haven't seen the ramifications of that yet, because when you look at studies and you look at surveys, you'll start to see meibomian gland changes, like, for example, in people's like early 20s, but they don't really present with ocular surface inflammation and tear film instability problems until their early 30s. So it happens about a decade sooner. And think about it, we're just 4 years out from the pandemic, and seeing our digital device use skyrocket through that, and especially in children with everything that happened with schools. And I have 2 daughters. I see what they go through at school and at home. And so this is super important. And I don't think we've even really tipped the iceberg of what this is going to look like for people and over the next, probably 6 to 10 years. So I think this is important to start to really talk to patients about this and show them pictures. Even if you haven't have meibography, that's perfectly okay. You do not need like the imaging to do this. You just need examples of what you're looking at. So when you're pushing on those glands, and you can tell the patient, I'm pushing on your glands that make the oily part of your tear film that keep it from evaporating. And you can feel how hard I have to push. In a perfect world, your lid is making that push, but you can feel how hard I'm pushing, and it's not really doing anything. That, for the patient, gives them something tangible that they can really hold on to. And then you can just show them a picture. Here's what your glands look like. If you have meibography, great, show them that. But just use an image if you don't have that. But that, for me, that conversation of that tactile feedback where they feel how hard I am pushing, that resonates with people. So something that you might try tomorrow in clinic. And then when we look at eyelids and being able to inspect what's happening along the lash margin, I put this together because I wanted to just look at how differently I look at patients now. That was a lot of looks in one sentence, right? But when I'm inspecting the lids, used to, and this is the same patient, by the way, in these pictures. So that upper left picture, he's looking at me straight ahead. That's how I used to start all of my exams, just like that. And you can see that he's got some telangiectatic vessels. You can't really see a ton, but you can't see the base of the lashes. You can't really see collarettes at all. But if you have him look down, and all that's different on these next 3 images is the amount of magnification. So upper right is 10x, lower left is 16x, lower right is 25x. I live in the 10 to 16. I'm happy and comfortable there because I can still see the forest for the trees, right? I can see collarettes on every single lash. I can see telangiectatic vessels. When I go to 25 mag, it's very, I like to look at it because the picture is pretty. But what I don't like about it is I can't see those telangiectatic vessels as clear. And from a photography standpoint, it drives me nuts because the depth of focus is off. So I have like 3 lashes that are in focus and the rest of it's not. And that just drives me crazy. And you can see my background. You can see why that would drive me crazy. I have my books in a rainbow order. But my point to this is, if you simply have your patients look down, look at all the things that you uncover just with that one, I would count it like maybe 1,000, 2, 1,000, 3, 1,000. It might be 3 seconds that you're inspecting that lid, and it uncovers so many things. So that's how I've evolved, is moving from that top right picture to the top or I'm sorry, the top left picture to the top right or bottom left, one of those two. And then you can start to ask questions, and then you can start to teach patients along the way what you're doing and why. So when you look at mybography, again, we've already just talked about this. If you have mybography, I love it for education. That's kind of all I love it for. It's a picture in time that lets me educate where the patient is, but it doesn't give me anything about function. You know, it's the equivalent of evaluating a patient with an OCT, but not checking visual acuity or a visual field. I need function. I need to know, can the patient do their oil glands work? Yeah, maybe they have a whole bunch of normal glands that look amazing. But if they don't function, that's a problem, right? And they're not going to look like that for a long time if we don't address that. So we have to look at function, and we want olive oil. That's what we want in that top left picture, you know, and then we start to degrade and it starts to become cloudy, and then it starts to become toothpaste. And lots of times it does nothing when you push on the glands. And you can do that with your digits. I do it with my clean fingers. I like this MGD evaluator that's in this video. I'll play that again, just in case you missed it. But this was designed by Dr. Korb, and it was mimicking how tight the blink reflex is. So it was the PSI of your blink. And if you're utilizing that evaluator, that tells you what's happening with each blink, right? I like my digits because I can tell how hard I have to push to make something happen. And these 5 glands like this is exactly how I evaluate and document. So I will put 3 of 5 glands cloudy, and I do that, comma, 2 of 5 glands clear, comma, 1 of 5 glands nothing, or whatever. So that way I have those 3 different sections evaluated in the chart. It just says 3 out of 5 cloudy times 3, if that's what the patient had when I was pushing on those. So that's a great way. That's not difficult. You're not having to memorize some kind of new nomenclature. You're just identifying exactly what you see, and that's how you're recording that in your chart. So meibomian glands are the guardians of tear film stability. They are there to do 2 things. Meibum prevents evaporation of our natural tear that has all those nice little 2,000 components in it. And then the second thing that they do is it lowers surface tension so that you spread the tears, and the shearing force of the blink doesn't tear up the front surface. Well, we've all had those patients. They have friction issues, right? They wind up with filamentary keratitis. They wind up with lid wiper epitheliopathy. They wind up with epithelial defects. They wind up with recurrent corneal erosions, friction, and more friction. So the meibum is there for those 2 things, to prevent evaporation, lower surface tension. When that's their whole role, integral to what's happening on the front surface. Risk factors: as you have more birthdays, you're more likely to get it. Gender: when you look at anybody under the age of 40, it's equal opportunity as far as gender goes. Once you get over the age of 40 and you start getting into the perimenopausal and hormone changes, certainly more likely women. Contact lens wearers, systemic conditions like rosacea, any kind of autoimmune disease. Anyone out there ever seen a patient that has Sjogren's have good meibomian glands? And by definition, Sjogren's is aqueous deficient. But when you have enough inflammation and homeostasis breaks down, it will affect the meibomian glands, right? I've never seen a Sjogren's patient that didn't have, you know, bad glands. It just doesn't exist. And then symptoms: they're going to feel dry. They're going to be irritated. A lot of times they'll have foreign body sensation. Their eyes will burn towards the end of the day. And then fluctuating blurry vision is key. And we're going to see those changes like we just talked about. So we've looked at eyelids. We've looked at meibomian glands. And now we're going to look at cornea, and we're going to look at tear film. We're looking at tear breakup time. Is always a good one to see how fast the tears disappear. My favorite is tear meniscus height. That tells me normal, abnormal. Is it too low or too high? That's all you need to know. If you look at enough vital dye tear meniscus height assessments, you will know when it's not normal. If it's too low, you have an aqueous deficient problem. If it's too high, you have some kind of problem that either is conjunctival chalasis, a drainage problem. You've got something else that's causing symptoms that lead you down a different path. And then tear osmolarity, remember we talked about, we can't see that at the slit lamp, but we can certainly measure it. And I want to know if there's hyperosmolarity, because epithelial cell death is going to happen next. And I want to know where I am in that state. And if I have a patient that still has epithelial cell disruption, but their osmolarity is normal, and maybe we started treatment 8 or 12 weeks ago, it usually lags a bit. Like when your osmolarity normalizes, it takes about 8 weeks for your cornea to come back to itself. So that gives you an idea of like where you are in the journey with that patient too. So I use it as a marker in that way. And then when we're looking at lid margin staining, so here we're looking for those friction issues, right? As far as lid wiper epitheliopathy. And lissamine green is the great way to see this. SLK, we haven't talked about that one. SLK, you know, looking and have the patient look down, tip that lid up so you can see is there friction issues happening underneath the lid. And then of course, conjunctival staining, you can see beautifully with lissamine. You can also see it, by the way, with a Ratten filter and your fluorescein. You can see conjunctival staining that way as well, not just cornea. So those Ratten filters that you use to assess your GP lenses and your scleral lenses to see, do you have leakage? What's happening with the lens, fluorescein patterns? Use that Ratten filter on your tear film as well, so that you can assess the cornea and the conjunctival staining. So looking at all of those things, so we did lids, skin and lids, lashes, meibomian glands, cornea, conch. That's how I go through my whole like system of how I examine a patient. And then we finally get to lens, right? And then we get to the posterior part of the eye. But it sounds like a lot, and it is, but if you break it down like that and do it in a methodical kind of way, it saves you so much time in the end, and you'll be a better diagnostician. So let's talk about, you know, historically, how do we manage and treat patients that look like this? I mean, when you look at those lashes, you've got collarettes on every single lash. So warm compresses certainly can help liquefy meibum. What has evolved for me is if they have rosacea, I'm not a huge fan of heat, because it makes their rosacea, it can make it flare. So I don't love heat in a rosacea setting. If I'm just working on my meibomian glands, absolutely. Lid scrubs, you know, I still have patients on diluted baby shampoo, which is why I have this in here, because this is historic data. And this is what patients used to think. And this is what we all used to say, because we didn't know any better. We didn't have any other solutions, but baby shampoo is really drying. And so I don't want patients on that. I want them on a specific lid cleanser that isn't going to break the skin barrier and cause more problems down the road. Consistency. You know, I ask my patients, how do you wash your eyelids? And I had a guy one time and he's like, what do you mean? Like, I just let water run over in the shower. There are ways to do this intentionally. And so as a profession, we have an obligation to teach people these things, because where else are they going to learn it, right? They don't have any kind of, there's no school on how to wash your eyelids. No one learns that. You go to the dentist, you learn how to floss, you learn how to brush your teeth, how to like have good dental hygiene. We should be talking about good lid and good visual hygiene. It's the same, it's just different, right? And then, you know, talking patients through that and how to do that. We didn't have a lot of options. You know, if you had someone, you know, with Demodex blepharitis, we did the best we could with what we had, and it still wasn't great. But, you know, current therapies are very targeted. We finally have a democidal, and we're learning more as we go. When we're talking about meibomian gland dysfunction, we have ways to help with this, whether it's mechanical and doing thermal pulsation, heat and expression, where we deliver that controlled heat, and then going back through and expressing those glands because they're completely blocked. And you can clearly see on this one, you know, you've got that tight orifice and toothpaste coming out. So we have to unblock that. But, you know, I'm always curious, like, how do we get here? What could have I done if I saw this patient 5 years, 10 years, 15 years ago? Would we be here? Would I have to intervene? What could I do differently? And these lifestyle and environmental modifications, and then eyelid hygiene, well hydrated, decreased screen time, humidifier, especially in the winter months, sunglasses we talked about already. So we talked about posterior blepharitis pretty extensively with meibomian gland dysfunction. So let's take a peek at anterior blepharitis and a closer look. We have multiple things that can cause this, but the most common reason for blepharitis is Demodex. So you can have Demodex infestation, Demodex blepharitis. You can have staph blepharitis, bacterial blepharitis, and then seborrheic. But the most common one that you are going to see in your clinic is Demodex blepharitis. When you look at one survey that was done, 58% of the people coming into our clinics have Demodex blepharitis. When I started looking for this, when I learned that statistic years ago, my clinic, it's higher. It's very common. Symptoms are going to not always present themselves because the patient's not going to come in saying, hey, my eyes are red and they're real itchy. What do they say when their eyes are red and itchy? Oh, I've got allergies, right? That's what they all say. They blame everything on allergies. And then we wind up with complications down the road. So let's talk about prevalence and impact of Demodex blepharitis. This is a very specific type of blepharitis caused by the Demodex mite. It's the most common ectoparasite that lives on our skin. There's two types that live on humans, Demodex follicularum and Demodex brevis. Very high prevalence. And again, the 58% of our patients in our chairs have Demodex blepharitis, and it will cause eyelid inflammation, meibomian gland dysfunction, and it will make patients just not feel their best and certainly not have the best visual quality. So how do we diagnose this? Are we being intentional about this? What do we do next? So unveiling these challenges, and all it takes is having the patient simply look down, and you're looking for collarettes. You see a collarette, that patient has Demodex blepharitis, done. That's all it takes. It's that fast and it's that simple. So when you have a patient like this that you see, yep, she's got eyelash extensions. What does she also have? Demodex blepharitis, because she's got collarettes. And plus she's got all those like telangiectatic vessels crawling towards that inflammation. So these signs are there hiding in plain sight. But unless we're having the patient look down and we're being very intentional, we're going to miss this. And because of those overlapping symptoms that I talked about, itching, dryness, irritation, it mimics other things. The patient thinks, oh, it's just allergies. You might think it's related to their dry eye. They may not think anything. They may have reset their normal and they think this is just how their eyelids feel, right? There's a lot of reasons for us to be very intentional with that one thing. Have the patient look down so that you can assess and inspect the base of their eyelashes. Once we navigate that and we have that diagnosis, this becomes much easier to talk about because we have a democidal that we can utilize. So you have the patient look down just like this one. You notice, great, we've got all these little collarettes so you can see. And what that is, that cylindrical sleeve coming from the hair follicle and surrounding that lash, that is the mite waste and all the things they produce in that follicle coming out of the hair follicle. And you see that lashes are distended. In this picture, this patient's lashes are growing the wrong direction. Some of them are pointed straight in, some of them are pointing in and down. And so it changes the actual hair follicle and the way that it functions. And, you know, patient history, if you ask this patient, how do your eyelids feel? What are they going to tell you? Fine. Have you noticed that your eyelids are itchy? Not really. Maybe. I think it's allergies. I heard that a couple of times today. Show me where it itches. And when the patient reaches up and does this with their index finger, oh, right along the eyelid margin, right? that is Demodex blepharitis. If they reach up and it's in the inner corner and they're rubbing, with their fist, maybe it's allergic. Let's look for, follicles and things in the palpebral conch to confirm that suspicion. But look at the eyelids. Patients that wake up with itchy lids, patients that have foreign body sensation, patients that wake up with matted, watery eyes in the morning, all of those should lead you down a path of this patient might have Demodex blepharitis. That patient history is really key. And then looking for collarettes, that's what's so simple about this. And all you need is your slit lamp. You don't need any fancy equipment. I love taking pictures to help patients and talk about this with patients because I can show them, but you don't have to have that. Again, you can have a really good image of, lids that are normal and then lids that have Demodex blepharitis. And I simply tell patients, look, you have Demodex. This is a normal ectoparasite that lives on human skin. We all have it. It's just that you have too much of it and it's causing this problem, or it's going to cause this problem. And I now have a way to manage this. It's that simple. It doesn't have to be scary. It has taken me a few tries to get comfortable with that and to get my verbiage to what's authentic to me. But that's how I talk about it with patients. So we do want to, work on the actual mite, and we want to talk about lid hygiene. And then we just want to educate. This is normal. This is not something you did. This is not a hygiene problem. This is not something that means that you're like dirty or anything in any way. You haven't caught this from someone. I get that question a lot. Am I contagious? Those are all questions that come up when you're having these conversations. And so it is pervasive and it does damage the front surface. And that's why I'm so intentional about this, because when you look at how much of blepharitis is Demodex blepharitis, it's 70%. So it's the largest part of blepharitis that you and I see every day. And remember, there's two different types. Folliculorum lives in the follicle. Brevis are smaller, shorter. They live in the meibomian glands. But it's implicated in our meibomian gland dysfunction and rosacea, lots of things that you and I see. And so we're going to clinically see this when we look at those disorders of the lash. If you have patients complaining that their lashes are missing, that their lashes are growing the wrong direction, that they just have thinning lashes, they just don't like the way their lashes look, then we need to be looking pretty close because this may be at play. It can certainly contribute or be a comorbidity of meibomian gland dysfunction, because remember, once we have those flora changes, then we get inflammation and you produce lipases, and now we've got a whole problem with the meibomian glands. So all those things go hand in hand. We set that up at the beginning of this talk. And then you get eyelid margin inflammation. You saw those images as we've gone along, those telangiectatic vessels coming towards that lid margin. We're going to talk a little bit more about rosacea, but when you have rosacea, there's a strong correlation that you're going to have Demodex blepharitis and vice versa. And that's all going to cause conjunctival inflammation along with, eventually cornea and surface issue problems. But collarettes are the pathognomonic sign. This is a top patient, same person 6 weeks later after lotilaner 0.25% BID for 6 weeks. She was my very first patient that I treated. That was clinically my patient. My husband was my first patient I ever actually treated. She was my second. That was someone that I knew. I'm sure he would not be super appreciative that I'm sharing that with you guys, but we're all friends here, right? So you can see clearly that she's got collarettes on almost every hair follicle. And that is 6 weeks later after utilizing the drop twice a day for 6 weeks. So the mechanism of action of this is it's a lipophilic agent. So some people ask like, well, how does a drop get into the hair follicle? The problem is in the lash, but I'm putting the drop in my eye. And patients will often, like the astute ones will be like, how does that work? And it's because it's highly lipophilic. So it's going to chase that oil into the gland, right? And the way that this works is it kills the mite because it works on these GABA-gated chloride channels in their nervous system. So it paralyzes them. They can't eat because they're paralyzed, and then they die. And the reason we do it for 6 weeks is because the life cycle of a mite is about 16 to 18 days. So we have 2 life cycles that we've completed with that 6 week, or, in the Saturn 1 and Saturn 2, and it was day 43. So 6 weeks is what we ask patients to utilize. And if I have any of you out there that haven't prescribed this, haven't utilized this, this is a real result. That is from the clinical trial. This is my patient, real result 6 weeks later. When you look at the study, the run into the study, the patients could not use any kind of lid scrub. They couldn't use anything mechanical. They only were asked to use the drop. And so this is pretty compelling when you look at the fact that they haven't done anything except put the drop in. And initially, I was curious what that looked like clinically. And so I didn't have patients utilize anything besides the drop until I was just, because it was my own curiosity, right? But I do have patients start and maintain a lid hygiene where we're taking good care of the lids in addition to cleaning their lids alongside their medication for 6 weeks. And I have just some fun before and after. So that was my first one on the left, middle patient, same thing. And then that far patient, certainly those are all at the end of that 6 weeks. And again, now I have patients, utilize a hygiene treatment along with their medication. All right. So, how do you get to all these things? How do we make decisions in medicine? How do we take new information and apply it? Who helps us do that? There's lots of ways to do this. This Delphi panel was put together a few years ago, and then they published this in 2023. This was the original Delphi panel looking at Demodex blepharitis. And, how do we talk about this? How important is this? And then they published the paper. We just finished the second Delphi panel, which I was privileged enough to join on this one. And so there's more coming in this arena and more publications to help guide us on next steps and where we're going. But when we look at barriers, I think the biggest barrier that most of us probably have, at least I did, is first, I can't diagnose something if I'm not looking for it. And if I didn't have a good remedy, a good solution, a good treatment, I didn't want to talk to patients about it, right? But this is different. And now we have that. So we can't diagnose something we're not looking for. So I think that's step number one, is this is highly prevalent. 60% of your patients that are coming into your clinic have Demodex blepharitis. It's the most common form of anterior blepharitis, but it's highly underdiagnosed. So there's step one. We can't diagnose what we don't look for. Step number two is, okay, great. I see it. How am I going to talk to my patient about this? And when we look at that conversation, it can feel very intimidating. I'm going to tell a patient they have mites on their eyelids. How's this conversation going to go? And I think you have to practice it, but I don't want you to be intimidated by that. I've yet to have a patient that I couldn't manage or had like a weird reaction, and I've been doing, specifically prescribing for Demodex blepharitis for over a year, but I've been talking about it for about 4, knowing all this information and looking at the phase 2 data and, realizing that I was missing an opportunity to talk to patients about something. Then that conversation again becomes easier, but it's never going to be perfect the first time you do it or the second or the third. And you just have to do it. But I'll tell you my little speech again, just so you hear it and how simple it is. You have this little ectoparasite that lives on your skin. It's the most common thing on the human body. We all have it. It's just that you have an overgrowth of this. They're causing problems. It's causing that symptom that you just explained to me about your eyes itch or they're matted in the morning. It's that foreign body sensation that you get as the day goes. This is what's causing that. The fact that your contact lenses don't feel as good at the end of the day. Those are all things that this might, and because they produce inflammation, are causing. If the patient doesn't have symptoms and they're quote unquote asymptomatic, then I tell the patient, listen, you have this. Maybe you don't notice anything today, but it will cause a problem and we need to manage it. We don't want this growth to continue. It's going to cause a problem, and here's how we're going to manage it. And as long as you have that solution, the patient's going to be fine. And because the patient is utilizing this twice a day for 6 weeks, it's not a chronic therapy they're on for the rest of their life. Man, this is that much easier to talk about. And then you can talk about, how do we wash our eyelids? How should we take our makeup off? Those are all things that you can build into that conversation, or have a good handout on visual hygiene and those kinds of things. But this targeted therapy that we now have with lotilaner, 0.25% that we use BID, has been an absolute game changer, and probably one of the most easiest things that I have ever prescribed in the 25 years that I've been doing this, because it's so simple. Have the patient look down. They have collarettes, they have Demodex blepharitis, and then you prescribe lotilaner 0.25% BID for 6 weeks. And then I walk them through, here's the lid cleanser that I want you to do. I take an image and then I say, I'll see you in 7 weeks, because I want to see them after they've gotten the medication and done it. If they have, collarettes and they're symptomatic, I also like to remove all of that stuff in the office. You could debride it. You can do blepharoexfoliation. You can do like a zest kind of treatment that's okra-based extract. You can do any of those things if you want to remove the collarettes, because those are pro-inflammatory and patients feel better almost immediately. So I like doing that for the patient in the office. And then we prescribe the drop and they come back in 6 to 7 weeks. So again, where we're going with this is super simple. Patient looks down, you're looking at all this. They've got telangiectatic vessels, they've got collarettes, great. They have Demodex blepharitis, B88.0, HO1.001, HO1.004, upper and lower lid, or right upper lid, left upper lid, unspecified blepharitis with other I can't even say it. Acariasis. I don't think that's even right, but it's B88.0. That's what has to go on your chart so that you can prescribe this. So here's where it's interesting. And this was part of our paper that we published, because when you look at Demodex blepharitis, patients have meibomian gland dysfunction. Patients with meibomian gland dysfunction have Demodex blepharitis. Patients are able and they are allowed to have more than one diagnosis, right? And so the ways to like kind of maybe start to separate, but you can see there's a lot of overlap here, which is why we put this paper together. Itching. So meibomian gland dysfunction doesn't itch like Demodex blepharitis. That's one of the hallmarks. It's that itchy where they're moving their finger, like their index finger, across the lid margin. That is Demodex blepharitis. Sensations for a Demodex patient, watery, crusty eyes, especially in the morning. Meibomian gland dysfunction, typically they have this like progressive burning sensation, and it gets worse as the day goes, and it gets worse with low humidity environmental factors. Grittiness, both patients can experience, but particularly like in the morning when patients have their eyelids stuck to the front of their eye, that certainly can be a meibomian gland problem. Also could be aqueous deficient. Blurry vision that fluctuates, both. Photophobia, more common with meibomian gland dysfunction. Tearing and dryness present in both. Reflex tearing, well, maybe it's due to Demodex, but it can also be a response to dryness. So you see that these become like very difficult to tell the difference between, when we're just looking at symptoms other than the itch. And I have patients, I ask them, show me where it itches so that I can like really see that. But this to me is why we talk about this and why we need other methods to really assess the patient. Because if we just go on symptoms, ooh, that is hard because so much of them overlap. Here is a nice little pathway and step-by-step approach. This is inside that paper as well. I'm going to blow it up so it's a little easier to see. And this is a nice, like, does the patient have blepharitis? Yes. Okay. Is it staph? Do they have scurf? Or do they have collarettes? Great. We've got Demodex blepharitis. Primary treatment recommendation, we're going to do lotilaner and a daily lid hygiene. If we need more things and the patient has rosacea, then we're going to do those things. Plus, we're going to talk about IPL and doing things for the rosacea. So this is a nice, like, little way to talk with patients and get your head wrapped around, like, what are next steps, right? And then if we're looking at meibomian gland dysfunction, is it active? Do they have a chalazion hordeola? Is it obstructive? Is it non-obvious? Those are things that we want to know. And then how do we manage? And again, we're looking at rosacea because they almost go hand in hand when we look at meibomian gland dysfunction. So maybe these hopefully will help you as well. If you want to dig into that paper, there's a lot more details in there about the overlap between meibomian gland dysfunction and Demodex blepharitis. Remember, habits can be a problem. We've talked about this. I don't want to belabor this. We've already talked about lashes aren't there just for adornment and patient perception. Look for extensions, but sometimes it gets a little complicated in, is this glue? Is this a collarette? How do I know the difference? What do I do with patients that have Demodex blepharitis and extensions? So I put together this little slide that very clearly shows the eyelash extension that's glued to the anatomic lash. You can see that on, almost most of the lashes. And then you can see like one that broke off and there was like a little piece of glue there, but the lash itself is missing because the anatomic lash snapped off. And when you look for a collarette, you can very clearly see it's at the base of the eyelash and that you have that distension of the hair follicle. It looks like Mount Vesuvius, a little tiny volcano there. That's a collarette. Glue is going to be further down on the lash and it's typically round. It's not cylindrical like that. You can absolutely utilize lotilaner in these patients. I've had multiple patients. I wrote up a case report for it. It doesn't mess with the glue. You need to manage the Demodex with patients that have extensions. They will have a high bacterial load, so hypochlorous acid is also recommended. And I have patients utilize that twice a day. They have to clean these. They are very prone to Demodex blepharitis. Treat them with lotilaner, treat them with hypochlorous spray so that they have the bacteria covered as well. But, that gives you a good overview of like how to manage that in your patients. Eyelash serums, we've already talked about. I don't want to spend a bunch of time here for the sake of time. Let's talk a little bit about rosacea and eyelid margin health. We've all seen those patients with these telangiectatic blood vessels that extend onto the eyelids. It's a chronic inflammatory skin condition. It affects the face. 20% of the time, it winds up on the eyelids first before it ever gets to the face. So you and I are the ones that are very commonly talking about this with patients. They will often have Demodex. We don't understand. Dermatology doesn't understand. No one understands why this goes hand in hand, but there is a very, very strong correlation. There's no proof that it's causative, but patients will often have rosacea and Demodex, facial chosis, as well as blepharitis. So characteristics of rosacea, you're going to have those telangiectatic vessels, that lid margin irregularity. Often they have meibomian gland dysfunction. The patient's going to have that chronic redness that looks like almost like a blush. It gets worse with triggers like alcohol, sun, caffeine, spicy foods. The patients will experience like their skin feels tight. Sometimes they'll experience like their skin burns, it stings. they'll have like kind of like rough areas of their skin or all of their skin. And then that can wind up on the eyelids as well. And then we all know the ramifications of that with conjunctival redness and then ocular surface problems eventually. So education is key here, because if they can avoid triggers, that's helpful. UV, we didn't talk about that. Hot showers, those are all things that will trigger this. And then lid hygiene, I don't want to break that skin barrier. So we need gentle cleansers that, and somebody pointed something out, I think it was last week that I was doing a talk, and she made a great point that so many of the reasons that people don't wash their eyelids is because they've been told multiple times, oh, it's too harsh. Don't wash your eyelids with that. And so we've been told, and the public's been told for all these years, don't do anything around the eyelids. And it's good advice, but we need to be able to do something there. We don't want to break the skin barrier, because the skin, again, is 0.5 millimeter thinner, but we can do things like micellar waters and very gentle cleansers that are specific to the eyelid area that we can have patients use. And then for rosacea, continuing on, there's topical treatments. There is topical ointments, there's systemic treatments with azithromycin, omegas, and then there's interventional treatments that we all use, like intense pulse light and IPL. It's very prevalent. I think it happens now that I look for it. I have a large population with rosacea. It causes a lot of self-esteem issues, anxiety, depression, and then it has a lot of just associations with obviously ocular issues, but also GI issues, autoimmune issues, certain other things that can go hand in hand. And it's just for whatever reason, there is a deregulation of the immune system. That seems to be like the center of that pathogenesis. Is we have just this compounding event, and now we have all of these inflammatory pathways that get activated. There is a genetic component to it, but that's just a risk factor. This can happen to anybody, but the immune system just seems to go awry. And then you have these vessels that become more leaky, and then you start to grow new vessels, but it's not fully understood. We know some, but patients will ask you these questions, and that's why I have this tucked in here. So it's a dysregulation of the innate, the adaptive immune pathways. And again, genetic factors can contribute. Demodex mites and certain bacteria can trigger that immune activation. So that's why I think this is so important, is because, it's the chicken before the egg. But if we have a patient with Demodex and we don't do anything about it, did I put that patient at risk to have rosacea down the road? Maybe they have a genetic predisposition, and because they have an overgrowth of Demodex, now we've triggered another inflammatory cascade, and now they do have rosacea. I don't know the answer to that, but in my research and looking and reading all these papers, that's certainly a curiosity. And I definitely, want to intervene on the patient's behalf when I have something super simple that I can prescribe to the patient to see if I can't, interrupt that process. And then I do talk to patients about the triggers for sure. The way that we diagnose and classify this, I just have this like tucked in here just for like overall general knowledge. But the way that this was changed in 2017, they changed it based on how patients were being managed and establishing the diagnosis. And so when you look at this, it's the presence of 2 or more features: papules, pustules, flushing, visible blood vessels, alongside 2 diagnostic features: persistent erythema, so that redness that doesn't go away, and phymatous changes, which for most people, it's their nose, right? And if they have one, they have that or the other, and then they have presence of 2 or more major features that establishes the diagnosis. And so they tried to simplify this so it made for an easier diagnosis. And then you can have minor features that can also be present. And then some of these poor patients have all of the above. But this allows for targeted treatment, and we're very much part of that conversation, because our patients wind up with this on the front surface and on their eyelids. So that was a pretty comprehensive summary of how things wind up changing on the ocular surface that start with the lids. Here's my takeaway messages. Look at the skin, look for rosacea, look for inflammatory lesions, and then look at those sebaceous gland changes, not just on the lids, but look on the skin too. So skin is where we start, and then we're looking at eyelids. Position and closure, eyelash abnormalities, eyelid margin health, we're having the patient look down, and we're evaluating and inspecting what's happening at the base of the lash. And then you get to the meibomian glands, and then we get to tear film evaluation. We're looking at tear meniscus height, tear film quality, tear film breakup time. Do we have corneal staining? When we look at those margins of the lids, I want to push on glands. I want to know, do they function? Remember, I'm looking at 5, 5, and 5 glands. How many glands are functioning, and what do they look like? And then there we are on that posterior. So I'm going to have to change this order. I don't like this order. And then looking at conjunctival and corneal evaluation. So making sure you're looking underneath the conj. If you've got somebody with friction issues, making sure they don't have SLK, bulbar conj. I have this picture of the cornea, but I have it on there because of the Ratten filter. And then of course, careful corneal examination. But our key takeaways here are, we have to start with the outside and then work our way in. If we just start at the cornea and at the tear film, we've missed half the story. And so we have to really prioritize that and change the way that we examine patients. And it's not hard. It's just changing habits, which is very hard. But if we start our examinations with the eyelids and then work our way in, that's going to help our patients have the best visual outcomes possible, because we're not going to miss Demodex blepharitis. We're not going to miss a blink problem. We're not going to miss that the patient's putting neurotoxin in the orbicularis oculi. We're not going to miss those things that sabotage and thwart our best efforts. And one of the easiest things to diagnose that I have ever come across clinically is Demodex blepharitis, because you're looking for those collarettes, pathognomonic, and now we have a treatment that we can utilize that is democidal and will kill the mite, which is the root of the problem.